Welcome back, everyone. We're going to continue our pediatric series with taking a look at pediatric cardiac and perfusion-related emergencies. For paramedic providers, as we go into this, we're going to discuss pediatric cardiac dysrhythmias more in-depth and intricately with the PALS section, and for advanced EMT providers, other pediatric courses that we're going to take will dive further into the treatment of cardiac dysrhythmias and cardiac arrest management. So we're not going to spend a lot of time with this lecture focusing on those pieces, although we will mention them briefly. First, let's take a look at shock. So shock is the inadequate delivery of oxygen and nutrients to tissues to meet metabolic demand, right? Hypoperfusion, inadequate distribution of material. There are three types of shock predominantly. We have hypovolemic shock or low volume shock. We have distributive shock, which is dilation of the vessels or a widening of the tank, if you will. And then we have pump failure shock or cardiogenic shock. We differentiate shock through compensated and decompensated. Compensated shock are when clinical abnormalities are critical abnormalities of perfusion, but the body's able to maintain adequate perfusion to vital organs. Compensatory phases of shock are things like increased peripheral vascular resistance and increased heart rate, increased respiratory rate to perfuse the vital organs. So you're going to see those compensatory mechanisms, but the body's able to maintain adequate perfusion of heart, lungs, kidneys, brain, etc. Intervention is needed, particularly in pediatric patients at this point, to prevent the child from becoming decompensated. Kids compensate really, really well. The problem is when they start to decompensate, they fall off the proverbial cliff, right? Whereas adults patient, it's sort of a progressive move or transition into decompensation. With pediatric patients, they're compensating really well and then decompensate for a very short period of time before moving into that peri-arrest or cardiac arrest phase. Decompensated shock is defined as a state of inadequate perfusion. In this case, the child will be profoundly tachycardic for a brief period of time, and then they will become bradycardic due to the ultimate hypoxia of the cardiac tissue. Hypotension in the pediatric patient is a late and ominous sign, and you should be starting resuscitation on scene immediately if they're decompensated. Most common causes of shock in infants and young children are large volume losses due to trauma, and early signs can include things like tachycardia, pale mottled skin, cool extremities. Hypovolemic shock, as far as management goes, position of comfort if they're in that compensated phase, supplemental oxygen, oxygenate quickly and aggressively with these patients, keep the child warm. If there's external hemorrhage, control the hemorrhage, and then for advanced providers, your treatment's you're going to revolve around volume replacement therapy, so fluid boluses for these patients. With compensated shock, advanced providers can attempt an IV or IO access en route. If a pediatric patient is in a state of shock, we need to be moving quickly. Again, these patients move. When they move into that decompensated phase, they don't stay there very long. Time is not on your side here. Begin your fluid resuscitation with isotonic fluids only. For decompensated shock with hypotension, begin your initial fluid resuscitation on scene. If your patient's in a state of decompensation, you're behind the eight ball. Time is already passed, and you need to begin aggressive resuscitation to try and move back into a compensated state. And so this is why we would start scene treatment. And this is one of those cases where, yes, the patient's critical, but we need to perform interventions now. We don't have time to wait until we get to the truck. During distributive shock, you've got a decrease in vascular tone. This means that there's vasodilation and third spacing of fluid can occur. It's typically caused by sepsis in pediatric patient, and the treatment for this is volume resuscitation. The tank is bigger, so we're going to fill the tank. Again, this is an advanced level treatment, but for EMT basic providers, you need to be recognizing these early signs and getting ALS on the way to you or moving rapidly to where ALS is going to be available for these patients. Anaphylaxis should be treated with epinephrine and is one of the causes of distributive shock. Cardiogenic shock is a result of pump failure. It can be present in children with underlying congenital heart diseases like myocarditis, cardiomyopathy, or as well as cardiomyopathies, myocarditis, and rhythm disturbances. Signs and symptoms include listlessness or lethargy, increased work of breathing, impaired circulation, mottled pale cyanotic skin, can accompany with an enlarged liver, sweating with feeding, or history of congenital heart disease, and this is where history becomes important. For cardiogenic shock, the initial management includes position of comfort, supplemental oxygen, and transport. Fluid resuscitation in cardiogenic shock is generally withheld. However, this is why we start with very small levels of fluid resuscitation, and you should be reassessing continuously. So if your patient is in a state of shock and there's no apparent history of congenital heart defects or no obvious signs that it's cardiogenic shock and you're beginning fluid resuscitation, start slow for just a little bit, just for a second or two, and reassess frequently. If the patient begins to deteriorate with the admission of fluid, stop the fluid. Because this means that there's likely something that's cardiogenic in nature and may be problematic. The following confirms cardiogenic shock: increased work of breathing or drop in oxygen saturation or worsening perfusion after a fluid bolus. So if you're certain or relatively clinically certain on the outcome, or the cause, the etiology there of the shock being distributed or hypovolemic, aggressive fluid is important and needs to be done. However, if you're not sure, if you suspect that there's a history of cardiovascular disease in the event, which is rare, or a congenital heart defect, then we need to move very slowly and watch very carefully for admission of fluid and then cessation of that fluid. Cardiovascular emergencies, as far as dysrhythmias, are rare in children. They're the predominant cause of cardiac dysrhythmias or cardiac arrest in children is going to be due to respiratory insufficiency. Hypoxia leads to bradycardia. Bradycardia leads to further hypoxia, which leads to asystole. And that tends to be how cardiac arrest in pediatric patients progress. They're oxygen-driven or hypoxic-driven and ventilatory-driven processes. When we're looking at treating dysrhythmias, we're going to classify them based on pulse rate, right? Too fast, too slow, or absent, and signs and symptoms are often nonspecific. Bradydysrhythmias, slow dysrhythmias, are secondary to hypoxia in children most of the time. Initial treatment is airway management, supplemental oxygen, and assisted ventilation is needed. The presence of bradycardia in an altered mental status pediatric patient is going to be presumed to be hypoxic in origin, and ventilation with 100% O2 should be started immediately. That's going to be the circulatory cure. You may need to start compressions along with that, and we will talk about that in your resuscitation courses, but aggressive oxygenation is going to be key for these individuals. Try to identify and treat the underlying cause of bradycardia, other things that you may suspect: poisons, toxins, hypoglycemia, abuse, neglect, and trauma, right? Those are some of the things that you're looking at. You should initiate electrical cardiac monitoring, ECG. With sinus bradycardia, the rate's slower than the normal range for the patient's age. So while we're looking at less than 60, say for an adult patient, a heart rate less than 100 for a neonate is considered bradycardic. So you need to know your average age ranges and your average heart rates. For AV blocks, first-degree blocks are typically an incidental finding and are asymptomatic. Second-degree blocks are progressive prolongation of the PR interval. So if you remember from cardiology for my advanced level providers, you've got that prolongation or that progressive prolongation and then a drop in a QRS complex. The biggest concern here is that it may progress into something like a third-degree heart block. Brief mention of your bradydysrhythmia algorithm from PALS here, but we're really going to look at more up-to-date information based on PALS courses. Tachydysrhythmia is when your pulse rate is higher than for normal age. You're going to break those down further into narrow complex tachycardias and wide complex tachycardias. And this is a paramedic skill set here that we're looking at. But I think it's worth understanding and knowing for my EMTs and AEMTs what they're looking for and what they're looking at. Treatment is directed at the underlying cause. If the patient is febrile and that's resulting in a sinus tachycardia or narrow complex tachycardia, treat with antipyretics. If it's compensatory, right, it's not uncommon for tachydysrhythmias due to hypovolemic states, and it's a compensatory hypoperfusion shock state, then fluid resuscitation is warranted, particularly if they've got a history of infection or fever. Remember that fever induces an increased consumption of fluid, oxygen, and glucose. So this can be one of the common causes of underlying narrow complex tachydysrhythmias. SVT is the most common tachydysrhythmia in pediatric patients that requires treatment. Narrow complex QRS, absence of P waves, unvarying heart rate of a rate greater than 220 in infants or 180 beats in a child. Treatment's going to depend on perfusion and stability, right? This is where we're going to take a look at stable versus unstable treatment here. And then for stable treatment, we'll start with non-invasive techniques such as vagal maneuvers or vagal stimulus, and we can do that for neonates and infants with things like cold rags to the face. You can blow in the face of a neonate. If you blow really hard, they'll kind of gasp, and that creates a vagal response. For wide complex tachycardias, we're going to, again, look at predominantly electrical treatment or pharmacologic treatment based on stability, stable versus unstable. Treatment hallmarks predominantly revolve around things like CPR, making sure that you've got high quality CPR ongoing most of the time, except for during electrical interventions. For pulseless arrest, so pulseless VFib or VTAC, we'll move to defibrillation. My basic level providers, you need to be making sure that if you're working a cardiac arrest, adult or pediatric, that you have an AED with the appropriately sized pads on that patient. Follow the prompts for the AED. For advanced level providers, assess for VFib, VTAC, and treat accordingly based on current PALS guidelines. Asystole or PEA, defibrillation isn't indicated. It's going to be CPR. And we'll take a look at more relevant and recent algorithms in our updated PALS courses. Heart failure, this is when the heart cannot meet the metabolic demands at normal physiologic venous pressures. Signs and symptoms for this include things like tachypnea, retractions, and grunting. Children often have profuse sweating and increased work of breathing during feeding, which is an indication here. Other children can have things like tachycardia, crackles as a result of the pulmonary edema. Treatment for these patients include oxygen. Diuretics is usually a long-term care or a treatment that's delivered in the hospital. It's not something we typically do for pediatric patients in the prehospital world. And then inotropic medications that increase cardiac contractility. IV fluids with cardiac shock and heart failure use very, very cautiously. Myocarditis is an inflammation of the heart. It results in myocardial dysfunction and can ultimately lead to heart failure if untreated. Viral infections are the most common cause. Myocarditis is transport. For these patients, we're going to transport with cardiac monitors, make sure we've got IV access, but be judicious in fluid management. As we can see, fluid is a great tool for hypovolemia and distributive shock. It's a dangerous tool for cardiogenic shock. So you have to be vigilant as the provider in assessing these patients and assuring that you've developed a sound clinical decision-making and sound clinical judgment for the treatment of your patients. Cardiomyopathy, you've got things like dilated cardiomyopathy, which is a progressive dilation of the ventricles and poor contraction of myocardial muscle fibers. This is usually due to a viral infection or toxicity. Patients can present with things like fatigue, weakness, and signs of heart failure. You've also got hypertrophic cardiomyopathy, which is the heart muscle is unusually thick. The heart has to pump harder to get blood to leave, and patients can present with things like chest pain, dysrhythmias, dyspnea, syncope, and sudden death. Restrictive cardiomyopathy is where the ventricular walls are stiff and ventricular filling is impaired. Signs and symptoms are going to be similar to heart failure. We can kind of sense a theme here with the cardiac emergencies in the pediatric patient. Shock-related patients, fluid is going to be important for distributive shock and hypovolemic shock, and this is a perfusion problem that we can address accordingly with fluid. Oxygen causes most dysrhythmias. Hypoxia causes most dysrhythmias, so oxygenate aggressively for your sick pediatric patients. Make sure they have adequate fluid. If there are underlying cardiac diseases, fluid is not going to be your friend, so be careful. That doesn't mean you're going to withhold fluid if you suspect shock that's hypovolemic or distributive in nature. It just means for the first little bit, while you're administering treatment, continuously reassess your patient. Assessment and management for cardiovascular emergencies, right? Start with your pediatric assessment triangle that helps determine your acuity of presentation in your patient. Determine likely underlying causes for presentation, the patient's priority, and the need for treatment and transport. Repeat your assessment after each intervention and regularly reassess. This should be an ongoing process.